Good afternoon. Thank you so much for your time this afternoon and for the invitation to speak. As Dr. LeMasters mentioned, I have made a pretty dramatic change in my professional career. A little bit about me: I have no disclosures. This is the second career for me. So I started my career in finance and in business and decided mid-career to go back into the academic environment and go to medical school. So I spent most of my professional career both in finance and in my medical training in the Midwest. My training culminated at a fellowship at the Cleveland Clinic in bariatric surgery. So in 2016, after assessing my options for practice after training, I made the big leap to go back to the Northwest, which is where I grew up, and practice medicine and start my career in medicine in eastern Idaho. And some people say to me, why and where is Idaho, and is this even in the United States or is this Canada? But it is in the United States. It's far, far northwest, and this is what Idaho looks like. We have Jackson Hole 2 hours to the north, Sun Valley 2 hours to the west, and Park City about 2 hours to the south. Outside of Boise, I am the only full-time bariatric surgeon in the state of Idaho, so my expanse of patients can go as far as Salmon, Idaho, and northern Idaho, and as far down into northern Utah. And my goal today is really to kind of talk to you about what it's like to transition from an academic center such as the Cleveland Clinic to a 25-bed critical access hospital, which is where I practice every day. And also talk to you a little bit about what I've learned in the last 2 years, and hopefully be able to give you a little bit of tips for success if this is something that any of you are interested in taking on the challenge to practice medicine in a rural setting. Hopefully I can give you some nuggets of information. The demand for rural surgeons is actually increasing. 30% of the American population reside in a rural, quote unquote, I guess if you will, how that's defined is somewhat up to debate, but 30% of our population reside in a rural setting. However, only 9% of the surgeons practice in these settings. So in 2008, there was a surgical meeting that was conducted that mentioned that there's a 30% increase in demand of rural surgeons that will take place throughout the years coming up to 2020. Now we're knocking on the door, 2020, and those numbers are still very vague as far as what that demand actually is. Dr. Patrick Bailey, the American College of Surgeons, actually co-authored a bipartisan bill that was presented to Congress in 2017 that went so far as to try to define what a rural setting is so that the need can actually be identified and that resources can be directed towards meeting that demand for surgery. Advantages in my last couple of years, or my first couple of years outside of training, I wanted to just share with you my experiences and then again, hopefully offer you some advice. Some of it, you'll see some very common threads that have taken place through the previous conversation. So I want you to make a mental note of those things that have been duplicated in all of the presentations, because those are something that all of us are experiencing, and it's very real that you're going to experience that as you move out into your practice. Earning potential. There's a little bit of mixed information as you do some research on what the earning potential is in an urban versus a rural setting. But the bottom line is very plain that you will have increased purchasing power in a rural setting. There's no two ways about that. The cost of living is different in eastern Idaho versus Redondo Beach, California. So understand that you do have value in these communities, these rural settings, and you need to apply that notion of your value to your negotiation strategy that you bring to the table when you're constructing your contract. In some cases, it can take up to a year's time to recruit a surgeon to some of these rural communities. So again, I emphasize that you understand your value and you bring that to the negotiating table. Also, don't forget when you're negotiating to include very important things in your package, your benefits package. Talk about loan forgiveness. Your student loan forgiveness can oftentimes in these rural communities be negotiated into the contract, and you want to make sure you bring that up. They can also offer you varying degrees of sign-on bonus, as well as I got a random bonus opportunity called a housing stipend for a first year. I have no idea why I got that, but I took it. It was fine. I'll take it. One of the other advantages I've found in my time there at this hospital is that I've had a lot of autonomy given to me. I feel that there's less bureaucracy. I've been able to design a wellness concept from scratch. I've been able to go out and brand this wellness concept, trademark a couple of aspects to this wellness concept, and I've had full support of my administration. And I don't know that I would be able to do that in a large academic center. But listening to my patients' needs for the past couple of years and understanding where we need to support them better and give them better tools so that they can be successful on their weight loss surgery recovery, we've been able to put a pretty effective program together for them. I also have learned that, again, as a surgeon in a small community, you are respected in your field, and you have opportunities for leadership not only at the hospital level, but again at the community level. I am the chair of the bylaws committee, and there's not a lot of people signing up for these chair positions in these hospitals, so you have an opportunity to make a difference. I can affect change in the actual administration of my hospital based on my involvement in a bylaws committee level. We've also, last August, just opened our first medical school in the state of Idaho, so I also have the opportunity to be on staff there to teach and give back to the medical students, so I'm looking forward to being a part of the faculty there. As well as, again, in the community, we have limitless opportunities to conduct physician education. I'm hosting a symposium on Monday talking about diabetes and the effect of diabetes and obesity and the intermix there, and I'm actually able to offer a CME event. And these are very well attended in my community because our physician colleagues are so interested and hungry for information and education opportunities. Those are the advantages that I see, but the day-to-day challenges are also a very real part of working every day, and something I want to stress, that reputation in this size of a community is absolutely key. The word of mouth between patients is absolutely critical to your referral patterns. Your patients are often your neighbors, people that you see in the store, your coworkers. I've operated on multiple people in the hospital, and their local business owners. And I conduct my clinic and always make the assumption that the patient that I'm seeing next is a relative of the patient that I just saw, because likely that is the case. You do have limited resources in this environment, and for me to refer a very difficult case or a complication or someone that comes into the ER maybe that has a very, very complex problem, for me to send them to a referral center, that means they have to go to Salt Lake. That's the closest place, and that's a couple hours south. That means that the patient has to leave their family, leave their circle, their sphere of comfort. So you have to be understanding that these people want to stay in their home community, they want to stay in their hospital, and they want to have that care. So balancing your skills, balancing the resources at the hospital with making sound medical decisions is something that you have to take into consideration every day. On-call requirements, and you've heard this mentioned in a couple of the other previous talks, it can be very onerous, and it's oftentimes 1 in 2 or 1 in 3. So call is a very, very real component in a rural hospital. And also, if you're just coming out of training and you're used to having your senior residents or your chief residents or having very skilled attendings standing across the table from you, the day you start practice on your own and you look around you and it's all you. So you are making these decisions by yourself, and you have to have a good support structure that you create around you to help you make these decisions and to make sure that you're doing good, safe surgery. So tips for success, I was thinking back on my first, again, retrospect in a couple of years in practice now, and what do I wish someone would have shared with me when I was just coming out of training? And there was a paper in JAMA in 2002, and that talked about how do you make decisions between choosing a rural lifestyle versus an urban lifestyle. Well, I happen to have grown up in the Northwest United States, so I was very comfortable with a rural lifestyle, and for me it was somewhat coming home. But these are some of the things that you need to take into consideration when you're making these decisions. Do you enjoy outdoor activities? Do you have, you enjoy less traffic, less crime, living in a close-knit community as a trade-off for giving up some of those cultural amenities and some of the choices in goods and services and ethnic diversity and cultural diversity? You have to ask yourself what's important to you and what's important to your family as you're making these decisions. Evaluate your skills. As you come out of training, do you feel that you're ready to be able to be a solo, almost a solo practitioner in your area or in your particular field. As I said, I'm the only bariatric surgeon outside of Boise, Idaho. So I needed to go out and get other training. I need to be able to do my own pH Bravos. I have no GI support 24 hours a day. I have very limited gastroenterology support, so I have to be able to do some of these studies on my own. I have to be able to interpret my own manometries and so forth. So that may be that you need to go and get extra training of things that you didn't have exposure to enough in your residency or fellowship. So seek out those training opportunities, and they exist. You can certainly sign up for courses at conferences. Take advantage of your industry reps. I have a stapler rep that has been able to get me into several courses throughout the United States to hone some of my skills of areas that I wasn't 100% comfortable with when I left my training. And then there's also mini fellowships available if you have the time, maybe between fellowship and actually starting your job, or if you can negotiate about a 6-week, 8-week leave, you can take those mini fellowships and become more proficient in certain things that you feel that you need in order to service the needs in your community. I've also, as Neil mentioned, taken advantage of some of these Facebook groups that are available, and there's just a multitude of them, but I'm pretty active in all the ones listed up here, and I've been able to reach out to people, you know, that I don't even know, throw a case by them, see what they would do, get some feedback as to how they've managed certain problems that I've seen in my patient population. So I would really encourage you all to get involved in these programs if you're coming right out of training. And then I think this is probably one of the key slides here, is you have to evaluate that support around you. And you have to look and see what other physicians or surgeons are in that hospital that you will be working with. Are they willing, are they interested to scrub with you on a certain case that maybe you need a second set of hands, or you just want a second set of professional eyes that maybe not the first assist that you normally work with Monday through Friday, but you want somebody a little bit more skilled. Do you have physician colleagues in the hospital that are willing to do that with you? Again, look at the OR staff. You've heard this message throughout the other talks. Who is going to first assist you in your cases? Again, you're used to having an attending standing across the table from you, or a chief resident, and now it's just you. Who is going to be assisting you? And are you comfortable with the specific type of equipment that you've used in your training? If that's very important to you doing your case successfully and comfortably, then you need to ask for that OR equipment that you need in order to be comfortable. And then understand what your diagnostic and interventional capabilities are in the hospital, so that you understand the complexity of cases that you are able to handle in that environment. And then also understand what type of clinic staff that they're going to provide for you. And the relationships that you've forged through your training, I would really encourage you to maintain those relationships when you get out into your own practice. Stay in touch with your attendings and be able to bounce cases off of them. And then I've been able to foster some relationships at a university hospital that's close to mine, that I've been able to give them a call and ask them their opinion on certain cases. And we've been able to prevent transfers or prevent having to ship a difficult case down to them. If we can, usually just collaborate and share ideas, I can, again, keep people close to home and around their families. And as you've heard earlier in the talks, review your contract very, very carefully. Obviously, salary has to be spelled out very, very succinctly. Are you base? Are you base plus RVU? Understand, are you coming in as an additional surgeon, or are you coming in as a replacement surgeon? If you're coming in as an additional surgeon, how many years is it going to take for you to develop your practice and get your RVU base at a level where they can protect your salary? So that's a very important thing to understand when you're coming in. Are you an addition, or are you replacement? And then understand the bonus opportunity. Have the previous surgeons reached their bonus opportunities? Understand call. And again, things that we've already talked about, equipment, staff needs. See if they've created a CME allowance in your contract so that they will actually reimburse you for your ability to go to these conferences. And if you need to get extra training, you can attend the conferences. Understand the termination circumstances, and then the non-compete clause. In Idaho, it's actually 2 years, but that'll never hold up in court. If I ever wanted to push that, it's just something you have to be really cognizant of in your state. As the point was mentioned earlier, not very many new people coming out of training, less than 70% stay in that first job. So you need to understand, if you wanted to stay in that community and work in a different capacity or in a different role, could you do that based on your non-compete? So in conclusion, the need for rural surgeons will definitely grow and continue with the aging population. The work can be very demanding. However, if you ask the right questions of yourself and you understand what type of environment you feel that you can be most successful in, as well as your family can be happy in, and you ask the right questions of the hospital when you're sitting down to the negotiation table, it can be a very rewarding experience. But remember, you are a trained surgeon, you're a commodity, you're a very valuable commodity, and you have negotiating power. And that's just a picture I took on a hike we took last fall in the Tetons. So thank you so much.